All right, everybody, welcome back from the break. Let's bring all of that renewed focus and energy into our final panel of the day. This is a really crucial one because it's going to attempt to take the ideas that we've been discussing over the course of the day and show us their relevance in real-life settings around the world. To moderate this panel of regionally diverse experts is going to be Professor William Pan. Professor Pan is Associate Professor of Global Environmental Health at Duke University. He's an expert in the complex interactions between human activities and their environment and what drives impact on human health. Ladies and gentlemen, please welcome Professor Pan.
All right, thanks everybody for coming back. I know it's been a long day, but as we say where I'm from, we always save the best for last. So as Sally said, my name is Bill Pan. I'm at Duke University in the Nicholas School of Environment and the Global Health Institute. And in case you didn't know, Duke University is in North Carolina, which is on the eastern coast of the United States. And I get the honor of mediating this panel. And if you're an epidemiologist, I specifically want to say mediating and not moderating. And you probably know the difference between those. But we have three guests. Only two are here currently. We have Swati Mahajan, who is the Health System Strengthening Lead for PATH in Southeast Asia. We have James Colburn, who's the Senior Malaria Advisor for the Clinton Health Access Initiative. And hopefully, Peace Giagom Boka Kove, who is from the Ghana Environmental Protection Agency, and hopefully she will arrive very soon. She landed approximately at 4 o'clock. All right, so today is a very irrational day, and I want to know if anybody knows why today is an irrational day. And I don't know if James is still here, but he probably knows as a mathematician why today is irrational. It's pi, right? It's March 14th, 3.14. So today is called Pi Day. And why is that relevant? What is even an irrational number? Well, a simple definition of an irrational number is any real number that is not rational. But that doesn't make that much sense. But another definition is really that an irrational number is something that cannot be expressed as a ratio of two integers. And in the discussion of climate and health, I can't think of anything better than that description of why we're launching today, Pi Day, to discuss something as complex as climate and health. You know, it's something that's nonlinear, it's very complex to deal with, and most importantly, we have to deal often with very irrational humans. So today, you know, we've heard a lot of discussions from people and organizations who are working around the world to address climate and health impacts. We've heard things about what health systems should do. We've heard things what global agencies should be doing. We've heard about technologies, training needs, new frameworks, how to build capacity and resiliency. But in my experience as an academic researcher, I can tell you that without hesitation, that one of the things I learned the best from are the things I failed at. And I'm sure some of you guys can relate to the failures and the challenges you've had in implementing things. For example, my team, we've been working in the Amazon now for a very long time, and it took us 5 years to develop a malaria early warning system, finally validated in 2017 in Peru. We can forecast malaria 12 weeks in advance with 90% sensitivity and specificity. But the process was very painful, and it was very irrational. Nowhere did we come close to estimating and predicting how we were going to get to our endpoint. But now we face a new challenge in the climate health space. And this is the implementation research that I believe Monty Pangsiri from Save the Children mentioned earlier. It's been 5 years since we developed the system, but Peru still hasn't been able to adopt any of the technologies we've developed. They face enormous challenges in implementation, and it is a challenge that is at the regional level, going down to the community level. And the panelists that we have today might not call themselves implementation science experts, but they are working at the front lines of the challenges that we face in creating climate resiliency in communities. So I'm going to sit down with them now. So I do want to start this conversation, and we're going to start with James. So James, you've done a lot of work on health resiliency in Mozambique, among many other countries. And this includes work on developing surveillance systems, using different types of data for improved decision-making. Can you share some of the challenges and the successes that you've had in building capacity in communities?
Yeah, thanks, Bill, for having me, and for the Forecasting Healthy Futures for putting this on. I think this has been great so far, and had the discussion at lunch along the similar lines of how you kind of introduced us, that the discussion around what is needed and the need for a resilient health system is, I wouldn't say straightforward, but I think it's something that is not super controversial. But how we actually do that is a lot more complicated. So I said if I don't give more specifics about, at least maybe, like you said, what not to do, then they can call me out on it. So hopefully I at least don't get called out during dinner time. So I think understanding context in this case is important. And so what we were trying to do, like you said, was to create resilient health systems, I think, in Mozambique, and resilient surveillance system, I think, is probably a more specific way to put it. And our goal in doing that is to kind of incorporate continuity and flexibility of the surveillance systems, and so that we can sort of decrease the uncertainty that's associated with the impact of climate change. And I think some of the examples of how climate change affects Mozambique and health in Mozambique, one is cyclones. We talked about Freddie. Freddie hit Mozambique twice, same storm, and that was one of 18 cyclones that have hit Mozambique since 2018, as a matter of fact. So that, in addition, these kind of major disasters, in addition to sort of the daily or more silent impacts of climate change, which is, for malaria at least, changing seasonality, intensity, and distribution of malaria, as well as other climate-sensitive diseases, of course. So that's kind of our goal, is to associate or to decrease the uncertainty associated with those, and in a way that leads to actionable outcomes within the ministry. We talk about ownership, capacity building, and making sure that these systems, whatever we do, are implemented, not academic exercises. So that's the ultimate goal here with these, is to ensure that this is something that is used, leads to any kind of outcome or analyses we do, leads to a defined response in the program that obviously, hopefully, decreases morbidity and mortality. So that's our ultimate goal. And we've done that through a variety of different ways. We've done things like electronic reporting systems. So after COVID, we created an electronic IDSR system or basically digitized the existing system and distributed devices to all health facilities, so that what happened after some of the cyclones, when the health facilities are destroyed, all the paper-based reporting systems, the ability of data to get aggregated from health facility to the district level is just not possible. So that can be somewhat mitigated by digital health systems. And it also obviously increases the timeliness of the data, so that it's easier to use it for decision making. We've also created an electronic database of all the different malaria data. So taking into account not just the epidemiological data, the routine epidemiological data that's collected from health facilities, but also commodity data when we can actually get access to it, intervention data, entomological data, basically anything that the program might need to use it to evaluate the effectiveness of their programs and to inform or evaluate their performance, I guess, overall. Similarly, we've kind of done work with a group that was created a few years ago in Mozambique called the National Health Observatory, which has effectively the same goal as the system that I described for malaria, which is to have all climate-related, or all data related to health and climate in one place and have access to it, so that these analyses, these complex analyses, can be done actually without having to go through bureaucratic processes, requesting or paying for data in the country. So that's kind of the goal, or at least of what we tried to do to address some of those issues. I think the problems that we really have seen in the country A lot of them revolve around data, still, obviously. Data quality is a big issue. And by data quality, I mean all the different characteristics we're talking about it, timeliness of reporting, accuracy, representation. We talk about a lot of these early warning systems or these analyses that we do to define the interaction between climate change or climate and weather data and a disease or the incidence of a disease. You need to have them at the same spatial scales, the same temporal scales. And so ensuring that that is the case has been difficult. We've for the early warning system that we have in Mozambique, we've resorted to using satellite-derived climate data because it's available for the entire country. And it has the timeliness of the spatial and the temporal scales that we need to associate with the epidemiological data. But there's still issues with that. We still have to deal with all the caveats that come along with remote sense data. And in addition to that, I mean, the routine health system data that we have is, I would say it's good in Mozambique. We have data from over 1,600 health facilities, geocoded health facilities in the country. And each of those health facilities reports on a monthly basis a rich variety of indicators that can allow us to calculate effectively, I think, what we want. But it's monthly data, so if we're talking about doing things like predicting malaria outbreaks, having that temporal resolution isn't necessarily that useful. There is weekly data, but the quality of that data is not as good. So you're kind of stuck between having high quality or deciding to use between high quality data of a poor temporal quality and better temporal data at a potentially less quality level. So that's one of the issues around data that we have to deal with. Another one is the type of data that's available. And Jim Golden's talk highlighted a lot of the different available data sets that are around, or the different types of data that we can use to provide links, not just between malaria, for example, and climate change, but also any emerging diseases. Because when we talk about health system resiliency, I don't think we should be focusing just on one disease, but on the ability of the health system to, in the case of surveillance, report on multiple different diseases. So we've run into the problem of not having a lot of the appropriate kind of indicators that we'd want to enable the responses, or I guess the decisions, or even the analyses that we're looking for. Some of the specific examples of that would be, we do have some data from the community level. We have a community health program in the country, but there are, the exact number is eluding me, but it's about 5,000 or 6,000 community health workers in the country. And when you can think about the fact that we have over 1,600 health facilities, it's clear we're not covering the entire community. And so linking that aspect of community data with the health facility level data that we have in order to make some of these decisions is a big challenge that we're working on moving forward. And the community health workers that we have, they report on malaria, diarrheal diseases, and respiratory diseases. And so there's a clear gap, but also opportunity there to gain a lot more information, and need to expand that so that we can have that same sort of spatial and temporal linking that we are looking for sure. But even at the health facility level, one of the things that we have run into, and that I think is really important when it comes to resiliency and that flexibility that we talk about needing for a surveillance system, is being able to quantify that uncertainty that we're looking for. So when we have climate change or an outbreak associated, of a disease associated with climate change, a cyclone, a disaster, something like that, we know that cholera is going to be an issue, diarrheal disease, malaria, vector-borne diseases, but there are other diseases that we don't know, and I think we're stuck right now in a lot of cases of only being able to quantify and see what we're looking for. So one of the things that we tried to do was to incorporate in that electronic IDSR system is to incorporate basically fevers of unknown etiology, or RDT negative fevers that are reported. So we can begin to actually quantify that uncertainty. And then if we can quantify that uncertainty, we can say we have an increase in that unknown febrile illness. Then we can look at some of these other data sources that we've been talking about, whether we're using AI or simple statistics, and start to associate it with zoonotic diseases, increases in agricultural, zoonotic diseases, and any kind of land use change, any kind of population movement kind of things. And so that's kind of one of the things that we've been trying to go for, but has been an issue for sure. And A lot of opportunities there, but still challenges. Entomological data is the same thing. I think it was mentioned that using entomological data as part of malaria early warning systems would be a great way forward, but Mozambique, I feel like, has a very rich source or data set for entomology in the country. It's just for malaria vectors, of course, at this point, but also it comes from effectively one sentinel site per district out of 161 districts in the country. So imagine if we were sitting here talking about making decisions on where to implement IRS or to distribute bed nets based on data from one health facility in each district, in 161 districts. So, we don't have nearly the distribution or representation from entomological data that we do from epidemiological data. So there's that still disconnect that we need to work out. As well as the fact that we have emerging vectors like Stevenside that was mentioned earlier as well. Our algorithms for detecting mosquitoes or identifying mosquitoes now are based almost exclusively on what we know. So again, how do we quantify that uncertainty? And that's a challenge that we're facing right now as well, without basically looking for anything under the sun. So I think those are the kind of the specific data quality issues. And beyond that, I think we get into sort of the bigger larger picture issues, like when you have data from multiple different sources, and if we talk about any emerging diseases or any climate-sensitive disease in the country, then we end up with the need to look at data from multiple different agencies, multiple different sources, where, for example, we have the Malaria Control Program, which has great access to the data that's relevant to malaria. And then we have this epidemic prone disease database, the IDSR, that's largely reported to the Department of Epidemiology in the country. Then we have the National Health Observatory, which in theory should have access to that data, including from the Meteorological Agency. But when we initially started working on this, any agency within the Ministry of Health in Mozambique still had to pay for data from the Meteorological Agency. So clearly, that's not going to end up being or leading to quick routine analyses. And so how do we get all these people to work together to share data? Ideally, I think you would have an institute like the Health Observatory that has a legal mandate within the country to have access to all relevant data. But I think in practice, that's a lot more difficult than it is to actually just say. So those have been big issues that we've had to deal with as well, and we're still dealing with them. And I think beyond that, some of that is related to funding and the fact that most of the funding for these activities is focused on specific diseases. It's quite vertical. Most of I would say, for vector-borne diseases, 99% of the funding for surveillance comes for malaria. And hopefully we'll get to the point where we don't need all that, but do we work on spreading that knowledge and that capacity to, I guess, detect diseases out as we get closer to zero, or do we just hope at some point that donors will shift their priorities and not have to, I guess, deal with any kind of repercussions with that? And then finally, I think I'd just like to bring up the institutionalization and the ownership of these different, basically a resilient health system. So making sure that this is something that is owned by the country. And if we do something like create an early warning system that is based on AI, how do we ensure that the data collection, the data storage, and the data analysis and use is all something that the country itself can do, so they're not reliant solely on donors or external collaborations in order to get that done. So I think that's a difficult thing, and then sort of using that to promote openness to using the data for their decision making, whether that's using seasonality, analyses of the changing seasonality of malaria to determine when we're going to do IRS in the country or where to do IRS or do things like seasonal malaria chemoprophylaxis, being open to new interventions in general, which is something I would say Mozambique has been great at doing, but also thinking about challenges and opportunities. I think that most of what you'll hear is that climate change is going to result in an increased distribution or potential new geographic areas will have the potential for malaria transmission. But I think in Mozambique, it's probably going to lead to, sort of like the Sahel, less receptivity to transmission. And so how do we leverage that? Do we think about, okay, we can leave this and not focus as much or as many resources in these areas that climate change is sort of driving to where we want it to go anyways, and focus on the north, or do we help to accelerate that, knowing that we have a unique opportunity? And so a lot of those are questions that we're still trying to deal with and promote that sort of ownership and kind of critical thinking within the government.
Wow, so that's a lot to put on us. Government silos causing problems, data governance issues, AI, and reliance on global agencies to provide that AI support. And then, to me, everything that was underlying what you were discussing is ultimately who was the user and the policymaker that uses the information. It's all quite fascinating that I want to follow up on. Let me move to Swati for a second here. So your team, PATH, has developed novel ways to engage communities in communicating climate health risks using storytelling with early warning systems, all in Bihar. And can you describe some of these programs and explain what has worked and what hasn't?
Sure. So first of all, to begin with, how did we kind of identify these innovations? Maybe I'll just take a minute to introduce the process. Our work on climate change and human health in India is quite nascent. Like, we just began around 6 months ago, and when we decided that this was one of the upcoming priorities for us, we, with a lot of partners, floated a climate innovation challenge. The idea was to identify product and process innovations and not to kind of, try and create and reinvent something. Maybe we looked at technology solutions or products which were at the technology readiness level of 7 or 8, which can be readily deployed. And we looked at solutions in 3 major categories: decarbonizing health facilities, risk adaptation and risk mitigation, and also community engagement and capacity development of the communities. That's how we kind of, identified some of these innovations. And now we're working with 2 such identified innovations to help develop the product better, to kind of demonstrate the impact on ground and to demonstrate the proof of concept, and then kind of, trying to also take them to scale. So these are 2 different interventions. First of all, I'll talk about the community-based early warning signals. So this is being done in a couple of districts of Bihar. So just to set the context, Bihar has 38 districts, and it is one of those states of India which has poorest health indicators. And of these 38 districts, 29 get affected by floods year after year. And 15 of them will be worst affected, will be, kind of landlocked, and they'll be influenced. There'll be the access to health facilities and all will be cut for around 4 months every year, with loss of lives, a lot of outbreaks. Then in addition to this, Bihar is also prone to a lot of heat waves and cold waves. And the state has experienced an around 168% increase in lightning strikes over the past 2 years. And coupled with this, the literacy levels are quite low. And like I said, the systems are already very fragile. So that's how we kind of, decided to choose Bihar as one of the intervention geographies. And that's a challenge also, because you need to have a very robust community-based partner to take up this kind of a solution. So the solution that we've developed with a couple of partners is about having a voice-based participatory media platform that is based on crowdsourcing risk and disaster information from the communities. And also, it's also a disaster preparedness advisory. So the solution is deployed across all stages of a disaster or an event. So in the pre-event stages, it's an IVR-based platform. It's based on interactive voice response and has natural language processing abilities so that people in local language can use and record information on the platform and can also listen to it. So in the pre-event stage, the communities are kind of, mobilized through the local partner to call on the platform, register themselves, providing information around where they reside, the village, and panchayat code so that we can locate them, where are they located. And this, in the pre-event stages, this is also used to kind of crowdsource information from them about vulnerable communities, possible hotspots, areas of infectious disease outbreaks. And also it's based on, in this time, there is a playlist, which is a pre-recorded list that's available on the IVR platform. So the community members can kind of listen to that so that they have access to right information. So it also helps to kind of, prevent them from misleading information. And they can also record if they have any queries. So the NLP-based AI models in the platform they kind of identify those queries, classify, and then respond. As of now, because we're just training the model, so we also have a panel of experts who kind of look at the content, moderate the content, and if there's something that needs to be resolved, they respond. So this is how we crowdsource information. However, this is kind of also used and validated and triangulated with the existing information, which is based on historical trends and the data which is available in the publicly available portals like Bihar as a Bihar Flood Atlas. Then you can use the meteorological data, Google Earth Pro, and then you triangulate, and based on this, you can issue advisories. So these advisories are again issued as automated voice messages through mobile phones, and through the same platform, you send these messages. So, this helps us to address two major challenges with other existing advisory or preparedness alert mechanisms. One, most of the advisories or alert preparedness alerts that are currently issued are either not in local languages, or they are not in the formats which communities can access or understand or act upon. And second is that most of these do not provide location-specific forecasts. So the lead time that the communities get to prepare is usually very less. So that's what we're trying to address through this solution. And during an event or during a disaster or say an outbreak, you can capture real-time data, and it will keep on generating these advisories. And in the post-event phase, it helps in three ways. One, it helps to provide information around recovery. Second, because users can record their queries and grievances on the platform, so the experts who are moderating the content can also help them by linking them to the humanitarian response or various social protection schemes that the government has. Where can they access? What are the kind of provisions so that they can be linked? And lastly, it also helps to seek community feedback on the precision and the timeliness of the alert that was generated. So that's how the solution works. Currently, we are in advanced stages of developing an easy-to-use GIS application so that you can also geospatially use and look at the data. And then geospatial visualization will help in historical trends and also will help to locate vulnerabilities for action and decision-making by the government stakeholders. However, like I said, it's quite nascent. There are a few challenges, and there are some things that are working well. Things that are working well are because it's community-centric and user-centric. So there's a high level of ownership, engagement, which might be useful for sustainability. And since it's participatory and a bottom-up approach that you're using, again, it's very easy to contextualize. But the challenges are, at the same time, because you are crowdsourcing risk information, validating that crowdsourced data at times turns out to be a challenge. Second, in the pre-event phases, when everything is normal, getting the communities to engage with the platform, to continually look at the content, to kind of mobilize them to use the platform, at times is a challenge. You need either a very strong community partner, or you need a network of community volunteers who can motivate them to do that on a regular basis. And lastly, we're also wanting to kind of have access to IHIP, which is the integrated health platform, for overlaying surveillance data on this and also other sources of data. But in India, as would happen, everybody works in silos, and other from data sources which are publicly available, access to this data is quite a challenge. So that's also something that we're trying to navigate through the National Center of Disease Control, which owns the IHIP platform. And the other one, I'll just take 1 minute to talk about that. That is a community-based digital storytelling mechanism, which is again based on generating awareness among the communities. So basically, herein we're working with groups of self-help groups of women, trying to sensitize these women on the health risks of climate change and trying to build that awareness. So the idea is that you bring them together, do a sensitization. That's how you trigger a need to act, a need to acknowledge that there is an adaptation that is required. And then once that need is triggered, with the help of partners, we try and get these groups of women in a room for, we call that your storytelling sessions. You kind of encourage them to tell their stories based on their conventional knowledge, traditional knowledge, some case studies that they've seen in their surroundings, and share those. And we kind of, motivate them to put that on paper in the form of graphics. And then these stories are digitized. And once they're digitized, then we, through our partner, try and conduct dissemination sessions that are called community labs. So the idea is to share these stories, which are led by the community members to a larger section of the community, and then engage them into a conversation and kind of build up from there. And also it helps to crowdsource information and also, kind of get them engaged on this conversation.
So the interesting difference between the two examples you both gave, and James, perhaps I'm not going to say this correctly about what's happening in Mozambique, but it sounds like what's happening in Bihar, it's very much a community organic program, whereas in Mozambique, perhaps it's more regionally and focused down. Is that a correct? Okay. So going back to the question about the user, so specifically for Swati, so James was talking about uncertainty and quantifying uncertainty, and you had mentioned the lack of a lead time, and especially the problem of getting people to regularly use the information and the crowdsourcing. So how do you communicate that uncertainty to communities? Like, how is that done exactly, and how do communities understand that uncertainty when you're providing it?
So, there are two ways we're trying to do it. Like I said, we're trying to engage with some community partners who are already there, who have a strong presence, because penetration into newer geographies is always a challenge when you want to do a community-based intervention, because that rapport building, that faith, or that, the confidence building has to be done with the community. So that's what we're trying to look at. But however, in the platform itself, we kind of look at the backend data, and we analyze it on a fortnightly basis to see what are the most engaging content that the communities have listened to, what was the average duration for somebody, kind of kept on listening, say, I called and I disconnected after 30 seconds. The message was 60 seconds. So how many people completely listen to a message? When do they drop off? And what are some more engaging contents? And what are the pieces for which most people are either seeking information or they are recording queries? So this helps us to kind of also try and look at the content. And this content is anyways on a calendar. You kind of keep refreshing it. So this also helps to kind of inform our content calendar to make sure that this content is more tailor-made to the requirements or the information that communities are looking at. So that's also one way we're trying to do it.
Okay. And James, I'm curious to know how you engage the users. Well, actually, I'm curious to know if the users include the community health workers that you're obtaining the data from, and then how that data gets back to them and how they use it. How the forecasts, I should say.
Yes. So for the early warning system, like forecasting, that part at this point doesn't include them. We haven't, well, I guess it includes their data because their data is included in the routine health information system, but it's not treated differently, and we're still, you mentioned that after 5 years you were able to implement your system. We had our first training after probably more than 5 years in November in Mozambique, but it's still yet to be operationalized, I would say, and so we're still figuring out one of the key things, which is what happens when this early warning system provides an alert. Who's responsible for it? What are the specific actions that it actually leads to? And I think that's going to be the key between the system being an academic exercise and it being something that's institutionalized by the government. So at this point, I'd say that there's, well, unfortunately none. And in the future, we certainly want to get to that feedback, and I think there's a balance between putting too much on the shoulders of people that don't have the capacity or the tools for whatever reason to utilize it or to interpret the information and utilize it in the way that we'd want them to. And then, having something that's too centralized, of course, and I think a lot of this probably, some of the differences between what we're talking about here probably speaks to cultural differences or the health system differences. In Mozambique, it's quite centralized. There's been some move to decentralization, which has led to a number of confusing, duplications of acronyms and whatnot, at the lower levels of the health system. But I think we're certainly starting to push that way. We're also hindered by some of that same siloing within the government. The community health worker has its own program, which needs a lot of capacity building. We recognize that, but traditionally the malaria program hasn't worked directly or at least consistently with that program, and so there's still that barrier to get at. And then we have just, in general, the issues, like each of the community health workers is supposed to be tied to a supervisor at a health facility. And during one recent health facility survey we did, where we incorporated a lot of the knowledge and skills and experiences of the community health workers, one of the big things we found was these frequent trainings, or the routine trainings and feedback sessions that were supposed to happen between the supervisors and the community health workers wasn't happening. That was one of the big gaps that we found. So when you talk about feedback, even within that, the routine health system, or the normal health system in the government, where you're expecting like the community health workers to get feedback on the quality of the data they're reporting, their stockouts of their commodities that they have, and those kind of things, that's not happening. And so we have that big challenge to deal with as well. And that was sort of basically saying to you that I don't have a good answer for your question, but yeah, it's add it to the list of challenges.
I do want to open up the floor for questions if anybody has any. I have a lot, so I'm happy to pause in case somebody does have a question. Yeah.
Hello, that was so interesting. I'm Naomi Jacobs from Malaria No More and UK, and very much a communications person. So Swati, I was listening to you and just got so excited about some of the work that you're doing and how brilliant it is. And I just wondered if there'd ever been any thought, because from a communications perspective, I just very much think, well, why are they? I'd love to combine the data stories with the actual content storytelling, and actually we should be looking at it as one full loop, and whether there are any platforms that, I've seen other platforms like Gapminder doing that, and I just wondered whether that was something that you thought about in terms of collecting the data and then actually using that data as well to tell the story and making that kind of loop, because that's something as a content person we're always kind of trying to look for those brilliant stories that you're sharing and you're collecting anyway.
Thanks. I think that's anyways in the scheme of things now, but thanks for kind of articulating it beautifully. What happened was, when we picked up these innovations, these were with two different partners, and they were anyways based in two different geographies. But like you said, we are now also raising resources to kind of look at this, because Bihar, with funding from Bill and Melinda Gates Foundation, has a very strong SHG program that's called the Jivika program. It's quite mature in intervention, and these self-help groups are very well developed, and they're very vocal. And the government has already been using them for many other interventions, like, they've been, recently they've been used for many other programs. So we are also now thinking that, we'll be leveraging on that platform. So we are in talks with the concerned partners to see whether it can be done. The second thing, like you mentioned, existing structures or existing mechanisms. So Government of India 4 years before introduced the Ayushman Bharat program, through which we created a network of 150,000 primary healthcare facilities that we call the health and wellness centers. So these health and wellness centers, last year it was mandated that every health and wellness center should have a community engagement platform that's called Jan Arogya Samiti. So it'll be basically a representation of the community members. We'll also have the frontline staff, and maybe, say, the headman of the village is supposed to be leading that. And it'll be given some funds for local level action, local level participatory planning. So that's now what we're trying to also look at, that once we have more results, some collection of stories to see, and also we want to do, see, it looks very well, but we also want to do a quick evaluation to see whether it actually improves the knowledge, attitudes, and practices of the community. And then, based on what we learn, we'll try and leverage these existing interventions and try and combine both.
Excellent rational question.
So my question is to you, to both of you actually, and that's a common question. James, you brilliantly talked about the challenges, and I'm not sure which one is a bigger priority. I mean, the data challenge, the data sharing challenge, or the response mechanism challenge. But one challenge exists in both. So for Swati and yourself, in terms of government ownership, both of these initiatives are externally led initiatives. And Bihar, I know that it's profoundly funded by Gates Foundation supported. So in those situations, it is very easy to roll out these kinds of initiatives. Now, if you are to scale, or if you are to enable a government to scale these types of solutions at national level, how do you think that it would be possible? What can be the potential solution? You may or may not have the answer, but what is your current experience?
So I think for the early warning system in particular, it's probably the simplest way to answer that question, maybe just because that's the only one maybe I have a good answer for. And the way that we've done that is, again, grant through the Bill and Melinda Gates Foundation, so thank you guys for funding both of our projects. So what we're doing is building the database that I talked about. It was definitely created with external funding by, well, not by external partners, I would say, but certainly we had a very strong role in that. We were able to use a digital health company in the country, a Mozambican company, but the ultimate goal of that and our follow-on grant to that is to build that capacity to collect those data and to store those data within the ministry. So initially using either cloud-based storage or private party servers, that's now getting transferred to the Ministry of Health servers. And so ensuring that they have the means to maintain those servers, to troubleshoot any issues that come about from them, as well as to utilize the data that come along with the early warning system. And then for the early warning system itself, it's more of a geospatial-based, I guess, statistical background or backbone of it rather than, AI, which I don't think really makes the problem significantly easier or more difficult. But what we did is we created an R script that we embedded within the DHIS2-based malaria system that we have. And so in theory, all we have to do is to show the people that they just click on the dashboard, and then behind the scenes, hopefully it's something that we can teach. I mean, we need to build the capacity to be able to troubleshoot this, obviously, and there's some coding involved with it, but the fundamental aspects of it are that the epidemiological data is routinely entered into this database. The climate data is accessible through the Google Earth Engine plugin within DHIS2, so it automatically pulls those satellite-derived estimates of the key variables into it, and then it's run through an R code that hopefully we won't need to change, although we can certainly work to build the capacity to do self-evaluations, which I think is key to that. So I think those are the key components that we kind of look at to ensure that they have the capacity to do it. Ownership is a little more difficult, I think, and for this, the key aspects of that are that it's used and that we get that circular feedback cycle going, and so that the end users or the communities that are impacted by this are able to feed information about the utility or lack thereof of the system back up. We built in some things in addition to just saying, this is sort of an aside, but I think related, in addition to just saying, or having the system provide an alert saying the incidence will exceed this specified threshold, we also incorporate a level of confidence through exceedance probabilities. And so we can say we have 90% sure that incidence is going to exceed this threshold, which I think helps them understand some of the uncertainty associated with these predictions and sort of, I think, allays the fear about people saying, well, are you sure it's an outbreak, or are you sure there's going to be an outbreak associated with these things? And so that allows ownership over decision-making, and they can say, okay, the confidence level is only 50%, so do we want to mobilize significant resources in response to this alert, or do we want to save them for something that we feel more confident is going to happen?
I think James answered it beautifully, but I'll just add a few things. I mean, especially in terms of India, I think we'll have a long way to go. And like I said, the solution is very nascent. Some things that we definitely are doing very deliberately and intentionally is not trying to create parallel systems. Wherever possible, like I said, we have plans of aligning it with Jan Arogya Samitis or existing structures so that you have those organic linkages with the health system than creating a parallel system. We are also trying to see if we can work with the NHSRC to see if there can be some incentives for the frontline workers to get engaged with these kind of activities like digital storytelling, but that's a long way to go. And as you know, a lot of saying does not make difference. A little bit of seeing makes a lot of difference. So maybe first we'll have to demonstrate something on ground that we can take to NCDC and the ministry and the key stakeholders to kind of, then talk about scale up and then talk about transition sustainability. And I think for us, another challenge is a lot of it also, for climate, there's a lot of political will already on climate action in India. We're seeing that one of the tracks in our G20 presidency is around climate, but putting health at the center of that climate change agenda is something that we'll have to kind of also advocate a lot. There was a study, I'm not remembering the source who did it, I think Center for Policy Action in Bangalore did it, which said that in the last 7 years of discourse in the parliament, only 7 questions were raised on climate change in India. So that tells us about, what is the level of sensitization of our key stakeholders and the politicians. So I think we have a long way to go. I'll just stop there.
I'll give my own angle on that as well, Kaushik, just on my own experience. So our system works very similarly to what James described. I would say the biggest difference is that the way we try to build in ownership is that we have actually transferred technology and purchased equipment for local universities to run all of our system components. And so we provide a training program where we bring students and government workers to Duke University, or we train them in the field, especially during the pandemic, to train them in climate modeling, train them in epidemiological modeling. The thresholds and the exceedance probabilities are actually exactly the same. Like we communicate that the same way. But the most important thing is getting the tools in the hands of the people who live locally and making sure they have the capacity to run the system. We have another question.
I have 2 more.
2 more.
It seems that all the questions are coming from Malaria No More. I'm Prateek Kumar from Malaria No More, India. I'm kind of very new to this game, and this is the first time I'm trying to just imbibe whatever is happening around climate change. I'm a little more familiar. Health, I'm not as much, and the overlap, absolutely not. And I keep wondering, where does the battle really lie? At the end of the day, you have health workers who are stretched doing whatever they do. You have nobody in the climate space which has a field force, at least not in India and not in most of the countries that I'm aware of. You barely have monitoring stations around. You really don't have a field team. Who really would lead this battle, considering that the convergence is way off? So are there good practices, examples across the world that one could be looking at where, some kind of convergence happens? And, I'm a skeptic at this point of time that, forget about resilience. There's absolutely no acceptance. Resilience would come if you accept and then you fight out and, and then you build that battle where you can actually hope to overcome the adversities that might come through. There's absolutely no acceptance, and I'm talking about, say, for example, the Ministry of Health, Government of India. You have this wonderful department which actually deals with, public health, public policy and human health and so on. That department does not have a single personnel on ground and is looking up to people who do reproductive child health programs to actually support them. So what are some of the best practices that are out there where we can really have a hope beyond the discussions that we have happening here? And I know technology can play a fantastic role, but when will that happen? And are they, again, I repeat the question, are there good practices? Is there something that even the North, the global North has to offer to us? Because frankly, I'm not seeing enough examples of that. Question to all 3 of you.
So, like I said, I'm also fairly new to the space, but I can try and answer in terms of maybe just sharing on what is already starting happening. And I may not be the best person to answer about best practices, given that this room is full of people who have, more experience than us. So I'm certain, you're aware that NCDC also has a division on National Program for Climate Change and Human Health. So in India, we have a National Action Plan on Climate Change and Human Health. So the first National Action Plan on Climate Change was initiated in 2008. But then health was just one of the components of it, and it was largely around transition to clean energy, and it was about agriculture. But in 2019, India developed the first draft action plan on National Action Plan on Climate Change and Human Health. And like you said, there are no people on the ground, but since it's about an intersection of climate and health, so they are relying on the existing health systems and the health workforce. So a couple of things that have already been done is that every state has been asked to nominate a state nodal officer and a district nodal officer on climate change and human health. Every state has been asked to develop its own state action plan for climate change and human health, given that health is a state subject. In India, it's a federal subject. And out of 35 states, 18 states have already developed a draft plan. I mean, we cannot comment on the quality, good, ugly, bad, but they are there. At least that effort has started. Then every state has also been asked to nominate district nodal officers. I do agree that it'll be somebody getting an additional charge, but at least we are trying to make someone accountable, we're trying to put someone in the driving seat to take that initiative, and all of them are now being trained. And there are 6 sets of priority diseases that the government of India has identified for climate action. These are heat-related illnesses, NCDs and mental health, respiratory, cardiovascular, and air pollution-related diseases, nutritional disorders, and I think vector-borne diseases and waterborne diseases. So out of these, in 3, there is a fair progress in terms of air pollution and respiratory illnesses, in terms of nutritional disorders, and also in terms of heat-related illnesses. There is already a health adaptation plan in place, and surveillance mechanisms are being developed. And the states have been trained on all of these. The district nodal officers are being trained. And in fact, that's also one thing wherein PATH was first approached by NCDC on, because PATH has a fair long history of working on vector-borne diseases in India. So we were asked to kind of work on the health adaptation plan for climate and vector-borne diseases. So every health adaptation plan comes with development of a communication strategy, a surveillance system, and capacity building materials. So I think in terms of planning, we're now trying to do things. So the idea is now to close the implementation gap and see how well can we execute these plans on ground. I do agree, because this requires multi-departmental coordination, and in India we know intra-departmental coordination in health is a challenge. Let's not even talk about interdepartmental coordination. That's a far-fetched dream. But I think we've begun, so that's what I know about the existing efforts, but about best practices and all, I defer to the experts on the panel.
I'm not sure I have good answers on that either, unfortunately. I think what the best practices are probably depend largely on the individual communities and a number of the characteristics within those communities. And I think that's where accountability comes in. I like your use of that word, and making sure that whatever it is, that the communities feel like there's some ownership, or that they have a stake in what's happening. And I think the first way to do that is to ask them what the priorities in their community are. And if you're doing something that addresses that, then that accountability and that feeling of having a stake in the outcome is going to definitely be there. There's a much better chance of it being there than a centrally run activity where partners come in and say, this is what we're doing. So, in Mozambique, we have a couple of examples of that, like building off of the Health National Adaptation Plan, and I'm not sure how much community input there was on that. I know that ideally there should be, certainly, but there were a couple activities around like coastal vulnerability that needed to be addressed, and then some flooding within like urban areas, and both of those ended up being good examples of addressing community needs by engaging with the community and taking advantage of that accountability and stake, or a feeling of having a stake in the outcomes that ended up being positive.
So just to add on to the accountability, I would say the biggest challenge that I've seen is the siloed ministries in government. That addresses everything that James was talking about with data sharing. It has to do with the Ministry of Environment, working with the Ministry of Health, which often doesn't happen, especially when you're saying, can you please provide us climate and land cover data from the Ministry of Environment to the Ministry of Health? That doesn't happen. That's a huge challenge. Even if the health system is able to get that data, There is a complete lack of training, and I'm not going to say about medical schools. There's a complete lack of training in public health on understanding climate change and using climate data for decision making. If you go to any school of public health, ask to see what are the climate science and health courses. They don't exist in many schools of public health. So when you've got decision makers not trained to use the data or not trained to make policy decisions based on the best available evidence, we're just not going to use it. And I think that's a huge barrier that needs to be addressed, among many that I think need to. Okay, I think we have time for one more question. Okay. We can't hear you. I don't think we can hear you.
Yeah.
Okay.
Sorry, I mean the resilient community should be community organized. Then there is so many issues regarding the methodology and the strategy to maintain them organized. It is according country by country, even regarding training, the change of behavior to get their sources. So I don't know if you have some opinion according your experience to explain how you have idea to maintain them organized to a long term, even with the support condition, because they usually change the behavior and according the need of the development program, they can change. Even the group member can be and live or change the area of their living daily. Suppose in one community, they have some people that get married, they will change to another area, and it will come trouble, not just in this way. That is why I'm asking if, according to your experience, what have you done or what do you know to maintain them organizing to get a success according to the need of the program we have to done.
I believe that was for you.
No, but can you synthesize the question? I've kind of not understood what he's wanting to ask.
I can't hear you.
Can you repeat the or synthesize or summarize?
So can you repeat the question exactly?
Maybe just the question, because
Sorry, we have to work with the community, but the community should be organized. How strategical we can get this result of a community organizing. We know that depending of a country, there are so many trouble in the way. Even the number of people to work with it, and the support and behavior, those kind of issues.
yeah. Thank you. So like I mentioned already, the groups that we work with are the self-help groups, which are already organized. They're together for a livelihood purpose, and then we're using this organization or these groups to kind of, generate awareness for climate action in them. So like you were mentioning that these groups have to be organized, that's what we were saying, that the intervention layers upon the existing community-based platforms. Either these are in the form of self-help groups, or in India we have at the village level a village health and sanitation committee, or it'll be in the form of this community-based structures which are associated to our primary care facilities that are called Jan Arogya Samitis. So it's not something that you have to kind of get into the stages of group formation that people have to come together, forming, storming, then performing. It's that these people are already there. These structures are there, and you just kind of using and leveraging the existing community mechanisms or structures to mobilize them for climate action.
I think we have time for one more.
Yeah.
We still have time for one more. Oh.
Climate scientist working in India Meteorological Department. Actually, my question is to Swati ma'am. whatever you are telling that first objection that 7 years, only 4 to 5, basically climate related, every parliament session, government of India, every parliament session in the year, there are 3-4 parliament sessions. We used to face so many 4 to 5 questions related to climate. Now, there are many questions where combining climate change as well as health. And it used to come to, because I have several publications on climate change and used to our report, we have to reply that climate change issue only, not health, because we are not that data. Now, regarding that, we have main problem what our moderator told, that there is a communication between this. We have the Parliament Standing Committee in India, Government of India, Science and Technology. In 2019, basically, they asked for climate change. There are several publication reports from my India Met Department, but they want recent data or that state-wise report. Even I have taken the lead role. We prepared for 29 states report on climate change. Okay, it is submitted to Ministry of, that is Parliament Standing Committee of Science and Technology, and it is different from Ministry of Health. And in the last year, 2022, as our NDMA, National Disaster Management Authority, even you may have that our WMO long back before this, we have Global Framework for Climate Services, GFCS, where 5 priority areas are there. One is disaster, DRR, disaster response, and health, water, agriculture. So basically, DRR, NDMA asked our ministry of basically environment, IMD is under Ministry of Earth Science, to prepare vulnerability atlas. So it came to me, and we have prepared basically from IMD for 13 disaster event vulnerability mapping based on all data, disaster data, and this 2022 district-wise mapping. And after that, again comes to NPCC's National Program for Climate Change. So initially, it was basically based on disaster management request, but our ministry, that health ministry, they invited, and I have delivered the lecture based on, and it can be further modified for health-related this. But there is, after, that is 2022, 1 year, almost over, there is no response from that health ministry, because once one product you are generating vulnerability, you have to generate particular specific health-related, each disease-related, the vulnerability mapping. So that is the main problem. There is a linkage of that. So it is actually, we have to come forward both climate, health, and your social, means all sectors.
So I think you highlight the problem of working across ministries.
Yeah.
Correct? Yeah.
So thank you, sir. Just to, maybe I'm sorry to make that correction. All my discourse is only on climate and health because I don't work with climate ministry. So that's what I precisely mentioned. The state action plans and national action plan for climate change was first done in 2008. But the health was just a chapter there, right? So I think rest you've already discussed. Yeah, thank you.
Basically, I know that each state's having climate action plan. Again, there is a communication. There is no climate expert in any state climate action plan. So they are only taking that as per government regulation. They have formed that climate action plan where climate expertise, even probably health expertise are missing also there.
Completely agree, sir.
Yeah.
Totally
Thank you for
aligned.
those comments. All right, thank you everyone for sticking around. I hope you enjoyed the day. I don't know if there's going to be a closing by Sally, but I hope you all enjoy dinner, ask some irrational questions, and have irrational discussions. Good night.
Thank you. Thank you so much, Bill, Swati, and James as well for that lively discussion that we just had, taking us across continents and different environments as well, each of which is feeling the pressures of global warming on its healthcare systems, but so many different approaches in there. It's great to see the power of storytelling as well coming into action in community development and capacity building, as well as looking at the shortcomings of effectively using data in public health. So thank you for that. Great panel, so much to take away. And I hope everybody had something to take away from all of the different discussions that we had today. Thank you to all of our outstanding speakers. Ladies and gentlemen, please join me in thanking all of our speakers today. How incredible. And of course, thank you to all of you for being here the entire day and coming in and being part of the discussion. So much more is to come tomorrow as well. But we are looking tonight, we're looking forward to getting together for dinner. Dinner will be at 7 o'clock, dinner and entertainment at Ingredients Restaurant, once again, where we had lunch. So just take this time to unwind, and we'll see you at 7 p.m. tonight. My name is Sally Musa. Have a fabulous evening ahead.